Thanks, Kathy. Hi, everyone. My name is Robin and I'm an arthritis educator. One of our roles, it's a very big role when we're talking with people about their arthritis, is helping them to understand and learn more about managing their pain. It's one of the most common experiences identified. Understanding pain is one of the most important things that you can do to start on your recovery. And if you're in pain, you're not alone. Right now, about 20% of people in the world have pain that has consisted or lasted for longer than 3 months. For everyone in pain, we say that it can just hurt a lot because your brain is wanting to protect you. Let's talk more about pain. Pain's not visible. It can be hard to explain to others. We can't see it. Even when we try and explain about pain, it can be hard for others to understand what you're going through, particularly when you're experiencing pain on an everyday, day-to-day basis. You may feel that your pain's not being taken seriously, and that can have a big impact on your levels of pain, not being understood. So what is pain? Pain is normal. We need it to keep us safe. Pain's protective. But pain depends on your brain's evaluation of danger, which makes pain a very powerful influence on our behaviour. Understanding pain changes pain. If we understand more about the pain experience and what is happening, we can make the best choices to change pain. And understanding pain fits well with a holistic treatment approach to pain recovery. And there's really strong evidence that pain education can decrease our pain ratings. There are 2 concepts that I want to talk about before we move into a bit more about pain, and it will help us to understand pain. The first is the concept of linear patterns that usually give us a clear order of events. The nature of this type of pattern means that something has to be completed before the next step can occur. An example of a linear pattern is the moon, where there's a series of phases that follow. If we think of pain in a linear way, then it comes back to one causative factor or existing pain beliefs, which we can often get stuck on. So each of these beliefs are held together by brain cells or brain activity patterns called neurotags, which exert an influence on the development of pain states. Let's contrast the linear pattern with emergent patterns, which can help us to understand the many interactions of parts that can make up this pattern. Understanding pain as being emergent provides us with new ways to understand interactions between the parts that make up the patterns. Pain is the result of many factors interacting with each other in our brain. So, for example, the flock of birds that we see in this image emerges from their collective activity, just as pain emerges in our consciousness as a pattern from our senses and thoughts. So thinking of pain as emergent alters the framework in which we can understand pain. Pain is made in your brain 100% of the time, and so pain is boss. There's no single pain center in our brain. Pain involves a spread of distributed brain activity that involves many brain areas. So let's think of an international airline map of the flight paths to different cities in the world that crisscross across the world. That's what our brain activity looks like. So pain is a conscious experience that involves many areas of the brain across time. Pain is an output from the brain. It's a conscious driver of behavior for the purpose of protecting tissues. Let's think of sitting on a hard chair, which I hope you're not, and getting a sore bottom. We may wriggle a bit, get up, walk around, grab a cushion to make the seat nice and soft. So when we experience pain, around 500 areas of the brain light up, including areas responsible for emotions, behaviors, sensory information, such as vision or hearing, memory, touch, high-level thought. This really reinforces the fact that there are many factors that combine together to make and modify pain, not just danger messages from our body tissues. Pain is a conscious driver of behavior, as I've said. We also have an alarm system that contains sensors that trigger constant messages to our brain. These sensors include sight, hearing, smell, taste, touch, and they're also part of our alarm system. Pain is designed to get you out of trouble. So the brain listens to the messages and weighs them up in the context of the situation and may or may not interpret these messages as pain. The tissue damage stimulates special sensors in our nerves. These sensors send danger signals to our brain. All types of pain experience involve thoughts, feelings, beliefs, emotions, and behaviors which are evaluated. Here are some examples where people who've had serious injury and no pain, which highlights that context plays a part in whether pain is made. So there's soldiers on a battlefield who have been injured or lost a limb and reported feeling no pain or limited pain. What about sports people who've played on to finish the game despite being injured? We also need to talk about the difference between acute pain and chronic pain. So acute pain means harm, it's protective. It's pain that's less than 3 months. It's really useful for our survival. So for example, if we didn't have pain, we wouldn't know to take our hand off that hot fry pan. Experiencing pain, acute pain, leads us to take action. So a broken arm is rested, put in a plaster cast, perhaps there's short-term pain medication that's used over a period of weeks, and the tissues then heal and there's no more pain. It served its purpose and is no longer useful. Let's now look at pain that's been going on for a while. So chronic pain, it relates to time. It's pain that lasts longer than 3 months. Chronic pain also involves the spread of brain activity that involves many areas across time. Chronic pain, though, does not always mean harm. Our brain has become overprotective, and the relationship between pain and what is happening in our tissues is not as straightforward or linear in understanding why there is pain. Chronic pain, therefore, can be less useful. If pain persists more than 3 months, the sensitivity of the tissues that detect changes in our body can increase. If pain persists, we also see changes in the brain too. It's as though the orchestra in our brain has stuck on the pain tune. Pain is complex. Our brain can still produce pain in the absence of any danger messages from our body tissues. You can have pain in a part of your body that no longer exists. You may have heard of phantom limb pain, where someone has lost a limb and experiences pain, itching, or tingling, which worsens if stressed. The feelings in the limb are completely real. Brain imaging studies show that the activity in the same brain areas occur whether you have a limb or not. So again, it reinforces that pain is made in the brain. Pain also relies on context to evaluate. So sensory information from our senses, vision, hearing, touch, as well as memory, reasoning, our emotional processing is evaluated. And the brain also considers the potential consequences of the responses, so pain or no pain. Pain experiments have found that a painful stimulus will hurt more if you're told it's hot rather than cold, or if it's paired with a red light, it will hurt more compared to being paired with a blue light. The point of these examples is to show that there is a variable and changing relationship between unpleasant stimuli and nociceptor activation, which does not convey an accurate indication of the state of our tissues. Importantly, it shows that other factors are involved beyond tissue change and things happening in our body. The context of the pain experience is important. For example, a finger injury is experienced as more painful compared to, say, that of a ballet dancer. Can you think why? It has more importance, the finger, for a violin player compared to anybody else, so the pain levels are going to be evaluated as higher. Another example is when we stub our toe and it hurts. We may rub our toe to stop the pain. However, it is the nerve endings in your toe that send danger messages up to your brain. And this is what is happening when you stub your toe. These danger messages tell the brain where there's too much stretch, it's hot or cold, and stubbing. But it is up to the brain to judge everything else that is going on at the time you stub your toe and decide whether it's a good dose, whether a good dose of pain is what's needed to help you change your behavior. If you stub your toe running across a busy highway, it's unlikely to hurt. But if you were wandering into the kitchen for a midnight snack and you stub your toe on the kitchen chair, it probably will. In this image of the elephant sitting on a person, we can see that the extremely exciting film in the second part of the image is having a positive effect on whether that person is having pain or not. And once again, it reinforces the situation that you're in and what your brain is evaluating is more important. So the film is prioritizing that it's less important to think about the danger of the weighted elephant sitting on you. As I've been talking about, the brain listens to the danger messages and weighs them up in the context of your situation. Danger messages include thoughts, feelings, and behaviors. Now, here are some examples of what we might say to ourselves. Pain means damage. This condition never heals. I have a diagnosis, but I don't really know what it means. We also have protection messages. So thoughts, feelings, and behaviors can also reduce danger messages to our brain. So it is possible to treat pain. Things are looking up. I'm sore, but I'm safe. So also being aware of a scientifically proven path to recovery, understanding your diagnosis, knowing you're not the only person to be in this situation, perhaps making an appointment to see a health professional or a physiotherapist, are all protection messages that can help us reevaluate the safety that we can help to reduce our pain. So what is pain then? Pain is about danger and safety. Pain does not exist when your credible evidence of safety is greater than your credible evidence of danger. So just to summarize, understanding pain fits well with the holistic, multidisciplinary treatment approach, which includes health professionals such as your doctor, pharmacist, physiotherapist, occupational therapist, podiatrist, along with all the self-management strategies that Zoe's going to be talking about, as well as Linda with regards to pain medication. Understanding how we can train our systems helps us to understand and seek answers to promote pain rehabilitation. So before I hand over to Linda, it's now time for poll 2. So if we take a moment, you fill out this poll, it will be good. Are you taking daily medications for your pain management? Okay. Right, I'll just now hand it over to Linda, who'll talk about medications. Thanks, Linda.
Okay, you can all see the results there. That's looking kind of what we expected. Thanks, Emily. We can have that down now, and we're going to move on with Linda. Thank you.
Great, thank you. Thanks, Robin. That was a great introduction. Hi, everyone. My name's Linda. I'm a community pharmacist here in Wellington, and we're going to have a bit of a chat about pain medication. So the role of medications. So we're going to be talking in depth about 3 different types of classes of painkillers. We're going to talk about paracetamol, which I'm sure a lot of you are familiar with. We are going to talk about non-steroidal anti-inflammatory drugs, and the abbreviation for that is NSAIDs. So you might hear me say that a bit. And we're also going to talk about the stronger painkillers, the opiates. We are going to talk about how these medications work, side effects of these medications, and how to take them appropriately. We are not going to be talking about other types of painkillers, such as things for nerve pain today. We're just going to talk about these 3 that I have mentioned. So let's dive in. We're going to talk a bit about where painkillers work. So of course painkillers are, their more technical name is analgesics. And as you can see in this slide, right down the bottom there is the site of trauma, the site where the pain has occurred. And we can feel that pain there. And it is also, the brain reacts to that pain also. And what we have is at the level where the trauma has occurred, so down in the body, that's pretty much where the NSAIDs are working. They're working at the site of pain. And then you've got paracetamol and the opiates working up to block the pain going to the brain. So that's what's happening with the different medications and how they are affecting how we feel pain. So we're going to talk a bit about paracetamol. Now, this is probably the most common medication, particularly for arthritis pain. We are really not entirely sure how it works. It is thought that it works by affecting some chemicals in the body called prostaglandins, mainly the prostaglandins that are in the brain, but strangely, they're not really sure how paracetamol works, and this does happen with quite a few drugs. We're not totally sure how they work, but they work, and that much we do know. So, and they work safely. So when we block prostaglandins, the body becomes less aware of pain and injury. We are going to talk a lot more about prostaglandins when we talk about NSAIDs, so I won't say much more about them right now. One of the main things with paracetamol is to take it correctly. The adult dose is 1 gram, and of course the standard tablets are 500 milligrams, so that is 2 tablets. It's up to every 4 hours, but no more than 4 grams in a day, which is about 8 tablets. It really is quite important if you're taking paracetamol to take it regularly and to take the right amount. Taking too little won't be effective, and you might get a bit disheartened that it's not effective, but it may be that you're just not taking enough of it. Some people do find it a bit of a problem having to take it 4 times a day, but it does seem to work best that way. Paracetamol is generally very well tolerated. We don't usually see too many side effects with it. That said though, all drugs can cause side effects. The most common ones are rashes and headaches and stomach upset and things like that. We don't usually see much of that with paracetamol. Its main issue is it's quite dangerous in overdose. It's really very harmful to the liver, and you must always be very, very careful with paracetamol with children because it's very, very dangerous in overdose with children. We do have some adult patients that struggle taking tablets and they will have liquid. So really you must be very, very careful when you have the liquid in the house if you have children visiting occasionally, because it is really quite dangerous in an overdose. So that's pretty much paracetamol. And now we're going to launch into the NSAIDs. And there, as you can see, there are quite a few of them. So the common ones, and I'm sure from what our poll said, a lot of you are on medication, so I'm sure most of you will be familiar with these. So we'll run through them. So we have ibuprofen, and its brand names are things like Nurofen, Brufen, Fenpid, Ibugesic. As you most likely are aware, all drugs have two names. So there's their chemical name, and in this example, that's ibuprofen. And then different companies will make this product, and they will give it their own brand name. So the brand names of ibuprofen are Nurofen, Brufen, Fenpid, things like that. So I know it can be a bit confusing, the two different names of drugs, but that's where that's coming from. And the other common ones, diclofenac's very common, naproxen, tanoxacum not so much so. That's a very, very strong one, and we don't see that used very often. So the way that the NSAIDs work is they block enzymes that cause prostaglandins to be made in the body. And we're going to look at these a bit more in the following slides. And by blocking these enzymes, the pain, the swelling and the fluid is decreased. And so when we block the prostaglandins, there's less swelling and there's less pain. So let's have a wee look about how prostaglandins work. So this slide here shows us that when we have an injury, our body gets busy and produces prostaglandins, and these cause blood and nutrients to rush to the site. And their whole point of doing that is to promote healing, and that's what we want, but it does cause pain in that interim. And there are certain enzymes that are responsible for making the prostaglandins, and these are called COX-2 enzymes. And what the NSAIDs do is they block those enzymes. So basically, if those enzymes can't work, we don't get prostaglandins released, and we don't get the fluid and the inflammation happening at the site. And that basically is how NSAIDs work. Now, it's a little bit more complicated than that though, because not all prostaglandins cause us problems. A lot of prostaglandins, there are prostaglandins everywhere in the body actually, and a lot of them are very useful. So we have prostaglandins in our brain that help with memory and other brain function. We have ones in our lungs that help with breathing, and probably most importantly to do with NSAIDs, we have protective prostaglandins in the lining of the stomach, and these help to protect our stomach from stomach acid. We also have ones in our kidneys, and they're very important for keeping our kidney function up, and of course our kidneys are very important. There are ones in the uterus, and there are also ones associated, as we were talking about, with heat and with inflammation. So how to take them? It's very important that you take them with food, and because we saw on that last slide, there are prostaglandins in the stomach, and they get knocked out when you take NSAIDs. So it's very important you take NSAIDs with food to protect your stomach. It's very important. And sometimes your doctor will also give you medication, something like omeprazole or Losec, again to protect your stomach, because those prostaglandins there are being knocked out. And because they can affect your kidneys, the dose of your medication will be changed if your kidney function is down a little bit. And of course, some of the NSAIDs are immediate release and some are controlled release. And the time of day you will take them will vary depending on how quickly they release. So we talked a little bit about this. The main side effects with NSAIDs are stomach upset, and that is because we've got those prostaglandins in the tummy. So you have them with food, and you might be given another medication to try and decrease that side effect, and that would be omeprazole or maybe pantoprazole, something like that. Bleeding is a real issue with the NSAIDs. Because some prostaglandins help with clotting, the NSAIDs can increase bleeding, particularly in the stomach. So you really have to be wary of that. Some asthmatics will find that their asthma gets worse because there's prostaglandins in the lungs. And we do have to be careful with kidney function. So there are certain situations where NSAIDs really cannot be used. Obviously, if you're allergic to NSAIDs, if you've become allergic to them, aspirin should not be used under 16 years of age. There are issues there. Because you may have seen on that previous slide, there are prostaglandins in the uterus. They cannot be used, therefore, during pregnancy or breastfeeding. Definitely not if you're on blood thinners because of that bleeding issue. They're really not a good idea. Definitely not if you've got an active stomach ulcer. That's a no-no. Need to be careful if you have asthma. Not all asthmatics have an issue, but some do. Definitely care with kidney, heart and liver problems, and that's where your doctor will guide you. Some are safer than others when it comes to particularly kidney and heart, and your doctor will decide what's best for you. So we'll move on to opioids. So these are our really strong painkillers, and these are used to treat more severe pain. And they are similar to, our own body produces endorphins, and these make us feel happy and they make us feel content. And this is similar to how the opioids work. They work by blocking the opioid pain receptors in the brain, and they prevent the pain messages from reaching the brain. So we don't perceive pain the same way. They're usually divided into two groups. There's weaker ones and there's stronger ones. So weaker would be codeine is the most common, and dihydrocodeine, and then the really strong opioids, which is tramadol, morphine, oxycodone, pethidine, fentanyl as well. And even though the strong opioids are classed together, there's still difference between them. The difference between something like tramadol and fentanyl could be a factor of 10. So even within those two classes, there is a lot of difference. And so if your doctor feels you need to be on the very strong painkillers, there will be differences in the strengths of what they may be prescribing. How do they work? Now, this is quite different to the NSAIDs, and this slide is quite interesting, I think. It shows the opioid receptors, so that's those pretty little purple things, and they are distributed, again, pretty much all through the body, particularly in the brain, which you would expect because that's where they're working for pain, but they're also going through, again, through the lungs, through the heart, and in the digestive system as well. So if we just have a look at that for a wee minute, and if you just sort of keep that in your mind as we're looking at this next slide. So the side effects of the opioids, the most common is the gastric side effects, so constipation, feeling sick, some people do actually vomit, drowsiness, and because they're acting in the brain, they can make us, they're working in the centres that make us feel good. There can be issues with dependence and addiction, but when prescribed properly, addiction is usually not such a problem. So the adverse effects, the main things we're seeing are nausea and vomiting, because the vomiting centre of the brain can be activated by those opioid receptors. And the same with constipation. So while it's working to fight the pain, it is also activating those receptors in the tummy. And that is why constipation is such an issue with codeine. So the best thing is to be aware of it and maybe to take steps to avoid it. The next thing obviously is the drowsiness and sedation, again because of those receptors in the brain. Can also be changes in heart rate. Not quite so common, that one. Finally, I think I just want to leave you with the most important thing with medication is to take the right medicine at the right dose at the right time. And I think that really is the most important thing with your medicine. So I think I will leave you with that and I will pass you on to Zoe.
Thank you, Linda. Well, just before I start, we are going to have a look now at poll number 3, please. So which of these best describes the way that you manage pain besides medication? So just take a moment to answer that one. Okay, so can we see the results of that one now? Okay, so a mixture there. Sometimes using other ways to manage pain being the majority. Great, well that leads well into the next section of the talk. So as Robin has already said, the brain is constantly weighing up information from both within and outside of the body to determine whether or not it is helpful to activate that protective system and produce pain. Two of the experts in this field, David Butler and Lorimer Moseley, refer to this as the balance between DIMS and SIMS. DIMS standing for danger in me, and SIMS standing for safety in me. We want the SIMS to outweigh the DIMS in order to reduce the perceived threat to the body and gradually produce pain outputs from the brain. This takes time, as we essentially have to retrain the brain to understand that it is in fact safe and needn't protect us constantly by producing pain. Just to reiterate that definition, DIMS are anything that makes you feel threatened, stressed, upset, or unsure. And SIMS could be anything that makes you feel stronger, healthier, more confident, and more sure as a person. So I'm actually going to set you some homework to complete following this webinar. What we would like you to do is work on identifying your own DIMS. What could you do to reduce the impact they are having on you? Eliminate them entirely or turn them into SIMS? Identify your own SIMS. What could you do to intensify their impact, multiply them, or add more of them? Sometimes it's about a whole combination of small DIMS that are resulting in your pain. Or we might have a whole bucket load of SIMS happening in our life, but one tiny DIM can tip us over the edge into pain experiences. The interesting thing about DIMS and SIMS is that they're very individual. One person's DIM might be another person's SIM. DIMS and SIMS can also switch teams, which is great. So we want to get rid of DIMS entirely if we can, or turn them into SIMS. Butler and Moseley have written a great workbook which is designed to help you through the process of understanding your pain, identifying your DIMS and SIMS, and shifting the balance away from danger and overprotection and towards safety, taking you through that gradual journey of retraining the brain to produce less pain over time. There will be a link at the end of the presentation to where these resources can be found online. One of the interesting things about DIMS and SIMS is that the sources of danger and safety can be really wide-ranging. It isn't always the obvious things that you might associate with arthritis pain, like a swollen, inflamed joint, for example. DIMS and SIMS can hide in hard to find places. So what I'd like to do in the next few slides is talk you through some of the categories that you might need to search under in order to identify your own DIMS and SIMS. It might be things that you hear, see, smell, taste, or touch. A DIM might be hearing that a health professional thinks that your pain is all in your head, whereas a SIM might be listening to your favourite song. It can be the things that you do. So a DIM might be waiting to take your pain medication until the pain gets really, really bad. Or a SIM might be doing regular gentle exercise. It's also about the things that you say. Saying, oh, arthritis is just old age, there's nothing you can do about it, might be a DIM. Whereas a SIM might be motion is lotion for the arthritic joint. It can be about the things that you think and believe. A DIM might be believing that your arthritis is only going to get worse over time, whereas a SIM might be believing that your health professional has it sorted. It can even be about the places that you go. A DIM, for example, might be going to hospital. Now, here's a great example of where individual differences might lie. So some people feel instantly worse when they walk into a hospital, whereas others feel instantly better. Another SIM example here might be being in a hot spa with your best friend. Now, speaking of friends, people in your life can also be DIMs and SIMs. So a DIM might be an out-of-date health professional, whereas a SIM might be having a partner that understands you. And finally, it is also about things that are happening in your body, but hopefully you've already understood that this is only a part of the pain picture. So a DIM here might be a pinchy feeling in the knee, whereas a SIM might be a feeling of having soothed muscles after a gentle massage. Now, Linda has already done a great job of talking us through our options for oral SIMs or medications. What are those other SIMs that might help you to live well with arthritis and hopefully reduce some of the ongoing pain associated with it? So most of these things fall into the things that I can do category. You can massage in topical creams or gels. So these tend to fall into two categories. Cooling gels can help when you have active inflammation, heat, swelling, or redness. These tend to have anti-inflammatory medicine in them, a small amount of which gets absorbed into the bloodstream. Examples would be Voltaren or Nurofen gel. You can also use heat-promoting creams, particularly for osteoarthritis, and when you have more of that day-to-day achy feeling. Look for active ingredients like capsaicin, which is a derivative of chilies that has been well proven for osteoarthritis pain. Other ingredients might be arnica or menthol. You can also apply heat or cold topically. In general, it helps to keep your joints warm by using extra layers of clothing and good quality woolen socks and gloves. You can also apply heat directly, for example, using a hot water bottle, a wet bag or heat pads, or a more general source of heat such as a hot shower, bath or sauna. You might even like to try a thermal heat exercise for the hands, where you put on a pair of rubber gloves and soak them in a tub of hot water. Or perhaps a nice relaxing foot soak, so using a tub of warm water with some Epsom salts, for example. Cold also has its place, again, more so for managing acute inflammation, heat, swelling, or redness. Exercise is one of the most integral parts of managing arthritis in the long term. We need 3 different types of exercise to help us manage our arthritis pain. Cardiovascular, so anything that gets the heart pumping. Strengthening exercises, because strong muscles help to support our joints. And mobility exercises that improve function and range of motion in the joint. There are a couple of great sayings to keep in mind when you are exercising with arthritis that might help to make it a more positive experience for you. So, move it or lose it. Motion is lotion. Synovial fluid helps to keep the cartilage healthy. move and my tissues will get healthier. I can be sore but safe. And apparently, even thinking about exercise can help. So if you visualize an activity that you want to do but currently can't, this actually refreshes this part of your brain. It's also really important to look at our general sense of well-being by looking into a healthy diet and weight loss if needed. Healthy eating contributes to that overall health and well-being, that sense of generally being safe, happy and well, which, as we've already highlighted, does help add to that pain management picture. So long-term weight loss has actually been found to improve symptoms of osteoarthritis in particular. It helps to reduce levels of bodily inflammation. It reduces pressure on our joints, particularly our weight-bearing joints, and it also improves our mobility. So a long-term weight loss of about 10% has been associated with improvements in pain. How do we go about this? It can be easier said than done, but it's really about making small steps towards healthy food choices. If you can, include fish, legumes and pulses, nuts, olive oil, and plenty of fruit and vegetables, especially leafy greens for cartilage health. This type of eating is really what we'd call the Mediterranean style diet. So we want to try and include omega-3 fatty acids in our diet, so oily fish, nuts and avocado, which can have anti-inflammatory properties. And of course, eating less saturated fats, which also helps to reduce inflammation. It's also about spreading the load on your joints. Nothing is particularly hard if you divide it into small jobs. Breaking a task like vacuuming down into chunks, like just doing several rooms rather than doing the whole house, can make it feel like a much safer activity. We also need to look at our priorities. There's a saying, do it, dump it, or delegate it. Do you actually want to be the one doing the vacuuming now that you have arthritis? Planning also helps. So to continue with the vacuuming example, you would want to plan the vacuuming for a day that you don't have any other heavy tasks on your plate. Work on your posture too. So good posture conserves energy and reduces strain on the joints. Again, for example, vacuuming with a straight back and the handle extended as long as possible can actually help to reduce pain. There are lots of different ways that we can look at protecting our joints. So there's a huge range of different supportive pieces of equipment or devices that can help people with arthritis. It's about finding out what's available to you locally. So some of our main centres do have specific shops that stock these kinds of products. There's also a lot available online, but even some of the bigger department stores now, like Bunnings, The Warehouse or Stevens, stock arthritis-friendly products. Now these are more likely to be successful for you, particularly the larger items like walkers, if you've been assessed or fitted by an OT, a physio, a hand therapist or a podiatrist. Finally, we need to look at mind-based approaches. So relaxation helps to dampen down the whole overprotective response and tap into those natural opioids in the brain, our endorphins. There are various ways that you can do this. It's about finding something that works for you, whether it's yoga, meditation, Tai Chi, deep breathing, or simply getting out and about in nature and getting some fresh air. Sleep is an integral part of good pain management. It gives our minds and our bodies time to recover from the day. If you're not sleeping well, it does become very hard to conquer some of these other pain management practices or get these SIMs into place. Finally, it's about connecting socially. Make sure the people you're connecting with are SIMs, not DIMs. For example, it might be time to stop talking to the classic nosy neighbour. Love and laughter are great forms of medicine. Spend time with friends or loved ones, pat your dog or your cat, or watch a funny movie. It's surprising how much this makes a difference to our pain. So just to reiterate your homework, hopefully that gives you a few ideas or a bit of a start. So happy sim hunting. I hope that you can find lots for your list. So this is just a little summary of everything that's been covered today. Pain is produced by the brain to protect us and overprotect us. Learning about pain is a powerful tool, And there are multiple factors that influence our pain. We might use those nicknames of DIMS and SIMS. Adapting your pain system back to normal can happen, but it's not likely to happen overnight. A holistic approach, which includes exercise, can help to improve health and well-being and reduce pain. So I'd just like to finish by putting up our final poll, and then there will be time for a couple of questions. Make sure that you scroll down to the end to answer all 4 of those questions if you can, please. Okay, that's great. So can we see some results up for that one? Great, okay, so most commonly osteoarthritis. Great to see that the information was relevant to you. That's our job done, and most of you have learned something new that you will use, so that's excellent. Okay, so you've now got your 3 speakers back again, and I'm going to hand over to Kathy to tell us what some of the questions are that you have.
Okay, the first question is for Linda, and the question comes, it's asking about long-term usage. So on long-term usage, what effects long-term would this have on the body? Now, I'm assuming that we're talking opioids. I'm having to make that assumption because it's not mentioned. What is considered an overdose? What is that, and what does this mean? Is long-term usage an overdose?
Okay, when we say overdose, it normally relates to taking too much at a single time. So long-term use and overdose are different terms. All medicines will have different issues when taken long-term. With the opiates, obviously you can get a bit used to them and they won't be quite as effective. And sometimes if those in particular are taken long-term, yeah, they can just stop being effective and they can almost make the pain a little bit worse sometimes. Which is sort of seems weird for a painkiller, but it can make pain worse, but that can happen with the opiates. With the non-steroidals long-term, sometimes there are definitely issues with the stomach and issues with the kidneys. Paracetamol doesn't seem to be too bad. There are a lot of people on that very much long-term. Yeah.
Thank you.
I hope that helps.
Yeah, thanks very much. I can probably answer the next question, that we're not actually talking about natural remedies today. That is certainly something for a future webinar.
Mm-hmm.
Okay. Now we have. But there is a question here about that. That there are the person who asks the question says that they have allergies to some of the medications that are being talked about and can't take the medications that are being described. And so you know, are there options for in the natural remedy field for things like that?
I'll start with that, if you like. Yeah, there definitely are. As was said, we're not talking about natural remedies today because that's probably a whole webinar all on its own. But I think the main thing to remember is that even with natural remedies, you can still be allergic to them. unfortunately. Just because things are natural doesn't mean there's firstly no side effects, and secondly no allergies, and they can also interfere with other medicines you might be on for your heart in particular, and if you're on blood thinners. So yes, there are plenty of natural options for pain, but you have to bear in mind that there are still problems that can occur with those medicines. That'd be my comment there.
And I guess just to add to that is to reiterate that I think medications are a part of the solution, but hopefully you'll have the impression by now that it's not the only solution. Certainly we come across lots of people who can't take anything at all and aren't eligible for a joint replacement, for example, and we can still find ways to manage pain, looking through all those different categories and searching through some of the other ideas that I shared with you at the end.
Yeah, thanks for that, Zoe. And that kind of brings us to the next thing, and that is when you said, can you give us a bit of an example about what you mean by turning a DIM into a SIM?
Yeah, sure. So, now I have to think of a really good one for you. So say, for example, currently you might find that the idea of exercising when you have a problem like arthritis in your joints is actually quite a DIM for you. A lot of people feel worried that they're actually going to do themselves more harm by moving the affected joint. So with some education around that, we can help you to understand that probably the worst thing you can do for an arthritic joint is to not move it at all, because it needs movement in order for that fluid within the joint to slosh around and keep it healthy. It helps to reduce pain and stiffness. So I think with a bit more education around, what exercise does and doesn't do to an arthritic joint, that can actually reduce the threat of the idea of exercising and help you to enjoy exercise rather than it being something that you're frightened of.
I'd also like to add, it's also changing DIMs to SIMs. If we think about the sort of language that we use to talk about our joints. So if we've been talking about our joints as crumbling or bone on bone, all these very scary, dangerous metaphors or descriptions about our joints, then changing it from a DIM, that type of language, to a SIM, that this is normal age-related change. I've got some good advice about how to move safely. Exercise is going to build up my fitness, my muscle strength. My joints are going to be stronger because of that. So that would be an example of changing a DIM in language to a SIM, what we say in that self-talk around our pain.
Okay, thank you. And actually that leads to what we can probably say is the last question, that the participant says that I walk regularly and enjoy this as a way of keeping fit. However, I experience increased pain after walking. Any thoughts on how I can manage this, as I don't want to give walking up? I have rheumatoid arthritis.
You, please?
I'm happy to go.
Yeah, you answer, Zoe.
Okay. I think the idea here is to perhaps take the amount of walking that you're doing back to what feels like a safe level for you. So not stopping walking entirely, but perhaps finding that sweet spot where you can walk comfortably for a certain distance without developing an increase in pain. So that might actually be about reducing the distance, the amount of time, or actually the pace that you're setting. What you can then do is gradually push the boundaries of how far you can walk without pain, but you're going to do it in a very stepwise fashion, because if we do it gradually, we're less likely to get that threat feeling or that danger feeling that something's happening in the joint, or I've done myself some harm here by walking too far. So it's about a gradual increase in your activity levels that can help reduce that.
Yeah, I'd also just like to add that perhaps looking at your footwear, that perhaps you have a podiatrist assess that you've got good supportive footwear, a stable platform, so that you're able to feel confident with your walking. So to reduce that shock absorbing impact as you walk.
Thank you very much. And it is 5 o'clock. So thank you so much to Robin and Linda and Zoe for their expertise. I'm incredibly, I've learned something today, and I always do every time I listen to my colleagues in this way. I basically, I want to say, watch this space. We have people here who are saying that they would like to hear more about natural therapies, and both the good and the bad things about natural therapies. So you know, we certainly will take that on board. I want to again thank Pfizer New Zealand. I'd like to thank all of you who've so readily and willingly taken part when you were given that opportunity. In the end, it's all about you, to help you, to encourage you, and to ensure you that you are not alone in coping with pain. So thanks very much, folks. And we will see you next time. Noho ora mai ora. Have a nice evening.